Hey team, my name is Jim Callaway. I'm with UAB Gastroenterology. I'm here today to give you a kind of a mini review and quick hits on a condition called eosinophilic esophagitis. I want you all to keep this condition in your differential diagnosis of dysphagia or difficulty swallowing, especially when you're working up solid food, kind of esophageal type dysphagia. So this condition results from inflammation of the esophageal mucosa and submucosa that occurs as a result of an allergen exposure. Now, these are typically aeroallergens or food allergens, and then there are 6 groups of food that are the common culprits causing inflammation in eosinophilic esophagitis. Now, depicted here are those food groups. That includes dairy products, wheat, eggs, soy, peanuts and tree nuts, and then fish and shellfish. And these account for usually up to 80% of the actual food causes for eosinophilic esophagitis and that inflammation. Now, regarding disease progression, eosinophilic esophagitis can present in childhood, where inflammatory symptoms typically predominate, and then over time, that inflammation is coupled with fibrosis, and then eventually fibrosis alone, which will lead to the detrimental changes to the esophageal mucosa and the submucosa and result in numerous esophageal symptoms. In children, on the kind of inflammatory side, nausea, vomiting, abdominal pain, food avoidance, failure to thrive may be seen. But in adulthood, when patients are typically have switched or are switching from the inflammatory to the more fibrotic stages of the disease, symptoms of esophageal dysfunction seem to predominate. Now, what are those symptoms that we typically see? The main things would be dysphagia, and then obviously the kind of the dreaded food impactions, which are where we may actually have to go in with our endoscopes and actually disimpact food that becomes stuck in the esophagus. But other symptoms that are common in adulthood would be food avoidance, kind of limiting certain types of foods or avoiding foods that typically would precipitate symptoms. But patients can also present with chest pain. It's also in our differential diagnosis for patients with have persistent heartburn. And then regurgitation can be another symptom as well, usually coupled with dysphagia or coupled with difficulty swallowing. But these are the constellation of symptoms that are typically seen in adults. So to touch also a little bit on risk factors, patients are typically diagnosed in adolescence or young adulthood. And this seems to affect males more than females. And then the Caucasian race are the most common race affected in the United States. So the classic presentation of a patient with eosinophilic esophagitis would be a young white male. But of course, I've had patients that are 6 years old or later be diagnosed. So we should have a high index of suspicion for this condition if patients are presenting with solid food, esophageal dysphagia, especially if they don't have a history of reflux or if they have any kind of allergic type predispositions. So I mentioned that. So family history is common in patients with EOE. And then I did mention allergies and asthma. And this is something that we see quite frequently. So of these patients, many of them will have concomitant allergic predispositions, such as hives, such as allergic rhinosinusitis, and asthma. And oftentimes patients will be managed alongside an allergist or with an allergist, especially if they've had a history of these other atopic or allergic diatheses. Interestingly, climate and season is something else that we sometimes think about. This disease seems to be diagnosed more frequently in the spring, summer, and fall months compared to winter, and that may speak to aeroallergens as well, but that's when we tend to see it more frequently. But of course, this is a chronic disease, so can affect any, clearly is a year-round problem for these patients. So I did want to touch on briefly endoscopic features of eosinophilic esophagitis. And I've got a depiction here from one of the recent guidelines. On the top left is normal esophageal mucosa. So this is kind of smooth, pale mucosa throughout. In the middle pane there are long linear furrows seen with eosinophilic esophagitis. In panel C are these little white exudates that can be dispersed throughout the esophagus, which are commonly seen with EOE. And then in the bottom two panes are actually obstructive type processes. So pane D has kind of trachealization of the esophagus, which can cause food to get hung up. And then in pane E, we actually have a true esophageal stricture there. Now, those are the kind of more dreaded obstructive processes when the fibrosis has set in. And they can clearly be a cause and a point of a food impaction. So lastly, to kind of quickly review therapies for eosinophilic esophagitis, since we talked about this being an allergen-related phenomenon, so if we can actually eliminate the actual causal agent from that, then that could be a potential therapy for this. So elimination diets have been used to actually decrease the potential food exposures for patients. And these can be done in a 2-food elimination, a 4-food elimination, or a 6-food elimination, actually hitting all of those different food groups, including, as I mentioned earlier, the dairy, wheat, eggs, soy, tree nuts, and then shellfish. If we can actually eliminate all of those things, that will be helpful in a vast majority of patients. Although clearly this is a very difficult thing to do because those are common foods that are around in the American diet. Now, PPIs also can help downregulate the inflammatory cascade to some degree, and these are cheap and easily accessible. Unfortunately, their true efficacy in EOE is less than 40%, and so these are tried frequently, but are not the silver bullet for most patients with eosinophilic esophagitis. Things that do seem to work quite well are swallowed steroids. So these are steroids that the patient, instead of inhaling, we use fluticasone inhalers and actually have the patient swallow them, or budesonide is oftentimes put in a slurry formulation. And this is swallowed to actually coat the esophagus, and this can be quite helpful at reducing the inflammation. These therapies actually work in greater than 80% of patients to help reduce the eosinophilia and help the inflammation in eosinophilic esophagitis. I talked about the obstructive features of EOE earlier, and esophageal dilation it can be quite helpful at reducing the obstructions in eosinophilic esophagitis. Now, of course, this doesn't address the inflammatory cascade in EOE, but it can be quite helpful in improving symptoms and quality of life. And so esophageal dilation is commonly done in this patient group and seems to be safe. The last thing I wanted to mention is the potential use of biologics or monoclonal antibodies. There's been a lot of work done in this. Although there are no FDA-approved drugs, just like actually swallowed steroids, nothing has been clearly FDA approved at this point. We do think that on the horizon there likely will be interleukin inhibitors of IL-4, IL-13, and potentially IL-5 that may have a role in the treatment of eosinophilic esophagitis. So I guess I want to say thank you for spending a few minutes with me today, reviewing kind of this mini review of eosinophilic esophagitis, and have a great day. Thanks, team.